Hello, welcome to this brief video on one of the most common conditions we see in our day-to-day practice, peripheral edema. I'm Martin Thomas. I work as a first contact physiotherapy practitioner for the NHS. Let us look at a case study. A 55-year-old lady presents to your clinic with bilateral knee pain. She will be classed as obese with a body mass index of 31. She has high blood pressure and she's on medication for it, no other medical history. On examination, you find that she has bilateral lower limb edema. And she also complains that she has been getting breathlessness progressively for the past 2 months. What conditions could be causing her symptoms? What management or further help would be appropriate to seek for this lady? So let us look at peripheral edema. The learning objectives of this brief video is to understand the types of peripheral edema and understand the most common reasons for peripheral edema to happen or occur, and also to act on peripheral edema appropriately. So edema is defined as extra fluid or excess fluid in the intercellular or the intracellular spaces. It takes about 15% of excess fluid, or the equivalent of 2 liters, for any visible signs to be seen with peripheral edema. The main causes for peripheral edema to occur could be because of a problem with the pump or the heart, could be an issue with the capillaries or the blood vessels being more permeable, hence letting more fluid ooze into the tissues. It could also be a problem with the filtration mechanism or the kidneys not eliminating sufficient fluid or eliminating extra protein from the blood. So when it comes to the heart, if you have a heart failure where the fluid is not pumped effectively around the body, you get fluid that accumulates in your venous system, and that can cause peripheral edema. If you get a right-sided heart failure because of any pulmonary conditions or otherwise, which is called carpulmonary when it's caused by lung issues, you can get edema in your peripheries. So the 2 main factors that determine edema or the fluid balance in your body is called the hydrostatic pressure and the osmotic pressure. The hydrostatic pressure is the pressure that is exerted by the fluid on the blood vessel walls. So when the hydrostatic pressure on the blood vessels is higher, fluid oozes into the body tissues. The osmotic pressure is what causes the osmosis between the tissue and the blood. The main determinant of osmotic pressure in the blood plasma is the protein albumin. Hence, if there is less albumin in the blood is thinner and extra fluid oozes out into the tissues, causing peripheral edema. The main physiological causes that cause peripheral edema are obesity, immobility, which causes dependent edema. So in a bedridden patient, you would find it more in the sacral areas, and in a patient who is either sitting or less mobile, you would find it in the ankles and in the feet. Pregnancy is another common cause for edema, and certain periods of the menstrual cycle can also cause peripheral edema. There are two types of edema. One is pitting edema and the other one is non-pitting edema. The difference simply being, with pitting edema, as the name indicates, when you push on the edematous area, the skin indentation remains for a period of time, so leaves an impression of the pressure on that particular area. The most common reasons for this to happen is because of cardiac failure, as we discussed earlier, which causes venous stasis or ineffective pumping of the fluid around the body, hence increases the hydrostatic pressure and causes pitting edema. Liver cirrhosis can cause pitting edema. Liver synthesizes the protein albumin, and it could also have an impact on the circulation. Malabsorption, where the protein intake is not absorbed into the main system or your blood. Nephrotic syndrome, where the kidneys are excreting excessive amounts of protein or albumin in the urine. Hence, this makes creates the imbalance with the osmotic pressure, causes peripheral edema. Starvation, again because of less protein intake, but it takes a long time for this to present itself as low protein in the blood and cause symptoms. An inflammatory bowel disease, again where the protein absorption is affected, can cause pitting edema. The two main reasons why a non-pitting edema happens is because of hypothyroidism and lymphedema. As we all know, the lymph channels drain the lymphatic fluid from your peripheries and around the body back into the venous system. So if there is any occlusion of the lymphatic system for any reason, this could cause edema, but typically this is non-pitting in nature. So when you press on the edematous area, it does not leave an indentation. Angioedema is caused because of the blood vessels. Usually it is a sign or secondary to any allergic reactions or infection, inflammation. Particularly if angioedema is seen around the mucous membranes, the face, it is a medical emergency. It needs to be dealt with immediately to avoid airway compromise. A rapid new onset of pitting edema is almost always caused by drugs. So the most common drugs that can cause a rapid onset of pitting edema are steroids, insulin, NSAIDs, and calcium antagonists. So if somebody has a new pitting edema of rapid onset, check if they're on any of these drugs. If there is shortness of breath associated with the edema, the primary suspicion is always a congestive cardiac failure. This again needs to be dealt with immediately and treated. The medical people or people who are able to order investigations and interpret them would order for a test called the BNP, or the brain neuropeptide. This helps the doctor to rule out or rule in congestive cardiac failure and treat them appropriately. The edema could also be unilateral in nature or bilateral. The main causes of a unilateral edema are DVT, or deep venous thrombosis, venous insufficiency, where the venous drainage system is affected, because the veins have valves in them which direct the blood towards the heart. And if these valves fail, you could get venous insufficiency, or that could be something that is occluding the veins that could be causing the venous insufficiency. Infection again can cause inflammation and unilateral limb edema. Trauma, which causes either the lymphatic drainage or occlusion to the lymphatic drainage system or occlusion to the venous return, can cause unilateral limb edema. Compression, which could be due to multiple reasons, again could affect the venous drainage system or the lymphatic system and cause unilateral limb edema. Tumors are one of the most common reasons where they cause occlusion of the lymphatic drainage system and could thereby causing the non-pitting edema. So when somebody presents with edema, check for any skin changes. Compare it to the other side if it's unilateral. Check if the skin is looking glossy, if it's looking red. Look for the Wells score, which we will discuss in the next slide. If you are able to and you're competent to do pulses, check their pulses, particularly the tibialis posterior, the posterior tibial pulse when it comes to the lower limb, and the dorsalis pedis. And in the upper limb, you would simply check for the radial and ulnar pulses. Determine the urgency, which is usually dictated by the speed of which the edema has developed. So rapid onset edema is always urgent. Check the calf circumference, compare it between the two sides, which is again one of the main features that determines the Wells score. If you suspect DVT or unilateral limb edema with redness, swelling, then Wells score is a standard tool that's used to decide whether this patient could possibly have a DVT. You could use a system like System 1 if you got inbuilt templates to do your Wells score, or if you don't have a template, you could use this website, which I commonly use. You can see all the questions and you can tick depending on whether this patient has this particular issue or not, and it'll give you the overall result or the score. So active cancer, the patient being bedridden for more than 3 days or major surgery within the last 12 weeks. Calf swelling measured 10 centimeters below the tibial tuberosity, presenting with more than 3 centimeters difference. Collateral superficial veins being present, which are not varicose veins. Varicose veins are usually present chronically, and the patients will know about it from having it earlier. If the entire leg is swollen, if there is localized tenderness along the deep veins, if there is pitting edema which is confined to just one leg or the symptomatic leg, if there is any weakness with the limb, and any previous history of DVT, all these will score a point in the Wells score. If there is a possible diagnosis or likely alternative diagnosis to DVT, that scores at -2. So if you get a score of 2 or above, you escalate it to the doctors so that they can do the appropriate tests and manage the patient appropriately. So most peripheral edema is managed medically. So if there is a new or acute changes with the edema, then seek medical advice immediately. Coming back to the case study, so this lady, because of her shortness of breath, was discussed with medical colleagues, had further investigations, and was confirmed to have congestive cardiac failure. At the same time, she could have had any of the other reasons for developing peripheral edema, as we discussed earlier. So in summary, if somebody presents with peripheral edema and has shortness of breath, has any signs of DVT, scores 2 or above in the Wells score, if they show signs of infection, if they have got redness and inflammation, if there are new changes to the pre-existent edema, or if the edema is of new onset, then seek medical attention immediately. And in case of angioedema, if you see any reactions around the face or mucosal edema, puffiness, that is a medical emergency to avoid airway compromise. Thank you for listening.